Esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2024. My name is Michał Macnar, and I have an honor of moderating Neurology and Neurosurgery session. I would like to cordially welcome the Eastern Jury, President of the Jury, Professor Monika Adamczyk-Sowa, and members of the jury, Associated Professor Joanna Siuda, Dr. Elżbieta Zech-Twardowska, Dr. Natalia Niedziela, Dr. Krzysztof Wierzbicki, Dr. Maja Patalongogiewa, Dr. Piotr Paździora, and Dr. Sylwia Pyrtek, who is with us online.
Yeah.
I'd like to explain to you rules of the session. The order of the presentations will be the same as in the abstract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic can assess the presentation. The assessment will be verified. On the session Neurology and Neurosurgery, all the presentations and the discussion must be run in English. If the commission will ask the question in Polish, because our commission can ask a question in Polish, you have to answer in English. I kindly ask the jury to assess scientific value, way of presenting, discussion, or contribution. In each category, you can get 1 to 5 points. To begin, I think we can start with the first presentation. It will be a time-10 pattern in baroreflex sensitivity and intracranial pressure after traumatic brain injury.
I would like to welcome on the first presentation of the session. I'm honored to start. I'm Weronika Domczewska from Wrocław University of Science and Technology, and my pilot study was about time trend patterns in baroreflex sensitivity and intracranial pressure after traumatic brain injury. And I would like to add that from the perspective of the computer science person, I'm not a medical student, I am a computer science student, so you will see another perspective on the topic. So when it comes to the background, I came across a study of my tutor of the work, which showed that traumatic brain injury affects baroreflex sensitivity and intracranial pressure by increased intracranial pressure after this injury. And that inspired my pilot study and exploration of the TBI dataset. Related to TBI, I mean a traumatic brain injury. And all the trials I took are based on the observations of the curves I saw. I saw the curves for almost 200 of the patients, but this pilot study is based on the 20 patients. And what was my aim? My aim was to develop an algorithm for automatic time trends pattern recognition for this baroreflex and intracranial pressure, those two neuromonitoring parameters, and propose the mathematical model for each signal. When it comes to data set, it was 20 chosen patients with traumatic brain injury from the Center TBI dataset. I was tracking the first 7 days after the injury. And if patient had a craniectomy done, then I stopped tracking this patient because it could affect the ICP signal. I needed to also use some techniques used for prediction. For example, I needed to take care of the data so they are completed. I used interpolation techniques to complement lacking signals. I also used rolling averaging technique to get average signals because I had signals tracked every 1 minute of the patient from being admitted to the hospital. I also needed to take care of the artifacts, for example, because there can be some calibration mistakes when it comes to machines tracking, and I needed to remove the outliers. And what can I say? I also needed to think about some criteria to exclude the patients, so decide which signal is good enough to track the information. So I decided to exclude patients who had more than 30% of overall missing signal. And if patient had an overall gap longer than 6 hours, then I decided to exclude the patient from the study. And when it comes to some averages related to the study, you can see at the screen the values, which I tracked when it comes to baroreflex sensitivity and ICP. And when it comes to like the topic, who was the patient, like an average patient I was tracking, it was a male. He was middle age, around 41 years. And when it comes to discharge status of the patient, most of them was a good outcome. And there were also patients with poor outcome. And when it comes to the Glasgow scale at the submission of the hospital, it was tracked. And as you can see, when it comes to the distribution of the patients, it was like evenly spaced around 10-20% of the patients with each Glasgow indicator. And when it comes to the results for the baroreflex sensitivity, I have two conclusions. When I started to track the signals, I got the calculations that showed that if I can fit a logarithmic function into the BRS signal, then the patient was poor outcome, or he had a low Glasgow scale value, for example, 3 or 4, after 6 months of the being at the hospital. And you can see example curves in here. And when it comes to the best fit of the function, it was a quadratic function, which suits best. When it comes to the error of the fit, it was no more than 20%. And you can see on there are two patients who were chosen. The left patient is poor outcome patient, and the right patient is a good outcome one. And here's the baroreflex sensitivity. When it comes to ICP, I have only one conclusion, that the quadratic function was the best fit for them. It was 85% of the cases. Just to mention, I tried 3 matches, and I did it based on observing the curves, how they are behaving. I tried with the linear function, I tried with the logarithm, and I tried with the quadratic function, and here are the results, as you can see. Here are the entropies, and I use entropy to measure the complexity of the signal. And from these two plots, we can see that the signal of the ICP for the poor outcome patients was lower complexity. To be honest, there is a little mistake because I didn't take into consideration on the spot the patients with who didn't die after the in the hospital. And I should have also taken into consideration patients with low Glasgow scale, but this is only this picture. When it comes to the calculations, everything is okay. I still have this thesis that a logarithmic function was a fit if patient was a poor outcome or had a low Glasgow value. And when it comes to the conclusions of the presentation, baroreflex signal may be predictive, and I'm going to study further those patterns to find more patterns, find more conclusions about predictive power of these signals. And my plan is to try to connect both signals together, both baroreflex and ICP, and check the correlations. And my plan is also to check more complex curves like third-degree polynomial or exponential function, and check if another functions also may raise some predictive value. And that's all I wanted to show. Thank you for your attention, and feel free to ask me questions.
Thank you for your presentation. I also want to correct myself and to welcome Professor Dr. Wojciech Bartman. I'm sorry for my mistake before. And now we can start the discussion.
Thank you so much for a really lovely presentation. It was very interesting for us. I would like to ask you about two questions. First, what was the process of randomization of these patients, because you have shown us that more about 80% of these patients of these cases were men. So I would like to ask about the diversity. It is my first question. And the second, what was your role in this project?
So when it comes to the process of randomization, first I did this quality checks when I needed to exclude some patients, as I mentioned how I did it. When it comes to the randomization, I just took 20 random patients. I didn't
But in accordance of admitting to the hospital, or what kind of randomization? Because we have more prevalence of men. Of course, maybe it is incidence, but it is important for example, publishing the data.
Yes, I know. I have a bigger data set. These calculations were done for the conference on the smaller probe. I have data for almost 200 patients. And this data set includes both women and men data, and it was just a random pick of 20 patients to do the calculations.
Thank you.
And when it comes to my contributions, I'm an author for the code for this algorithm to tracking.
Thank you.
Did you compare the influence of the ICP value to the creating of the curve? Like, for example, does it the beginning ICP influence the curve?
Both two curves were taken into consideration separately, but we started to take into consideration both of the curves, but it's done in the next step of the research.
Okay, thank you.
And may I add the thing that after this study, we have some other conclusion that if we take into consideration those signals both and we track the counter phases of those two signals, we can have a predictive meaning.
Okay, thank you.
Okay, if we have no more questions, thank you very much for your presentation. Now the presentation machine learning approach to mortality prediction after brain injury using volatility of neurosignals will be presented.
Can I start? Okay, so welcome everyone. My name is Ignacy. I study at Wrocław University of Science and Technology, and today we would like to present our results in machine learning approach to mortality prediction after brain injury using volatility of neurosignals. So a few words of introduction. Intracranial pathologies are one of the leading causes of death and morbidity worldwide. And according to the Centers of Disease Control and Prevention, an estimated 2.5 million people sustain a traumatic brain injury every year. And young people constitute the significant percent of the patients. And this is huge economical and social cost for the society, as treating this trauma is costly, and people after such injury often cannot work and are dependent on the help of others for the rest of their life. And treatment of the intracranial pathologies is confounded by the heterogeneity of patients, and biochemical norms doesn't allow for individual therapy. So we'd like to use neurosignals, which will allow us to do individual approach for each patient. And we want to identify the key parameters covering brain autoregulation and and the autonomous nervous system using machine learning supported with the explainable artificial intelligence to predict the patient survival. And the reason is that after brain injury, the disturbances in those systems cause secondary trauma. Our materials and methods. So at the beginning, we had 66 post-traumatic patients. We had to each patient around 98 meta parameters and 70 different time series parameters. And these recordings were 3 and over 3 days long. So we shortened them to 3-day long recordings. And it left us also, after some initial filtering, 45 patients. And we had categorical, continuous, and binary columns, and also these time series data. So we processed it using autoregressive conditional heteroscedasticity model to calculate volatility. And it left us volatility of the intracranial pressure, pressure reactiveness index, arterial blood pressure, and arterial blood pressure barometer index. And we also processed the binary and categorical data and removed some redundant columns. And final data consists of 88 different columns. And it's also worth mentioning that age of patients was 38, mean age of the patients was 38, plus minus 16 years. And also there were 10 women and 35 men in our data set. And then we split our data set to classical 80-20 train test split. And we used 5 seeds of those random splits using certified K-fold. And then we fed this data to extreme gradient boosting classifier with certified cross-field validation with 5 splits and grid search to optimize the hyperparameters. And our results, we used SHAP analysis to get insights on what parameters had the biggest impact on the model output. So we can see that volatility of intracranial pressure had the biggest impact of our model decision making, but it needs further investigate because on other analysis in other seats, the low value of this parameter consists both to the low and high SHAP value. And similar situations with the arterial blood pressure, but multi-organ failure, lack of it consists in the negative SHAP value, so it's something that we rather expect. Also similar thing is with the anisocrea, and you can see that volatility of pressure activity index also has a huge impact on the model output. Here is a confusion matrix for one of the seats. Okay, and here is aggregated confusion matrix for all of the 5 seats, and precision and recall, they vary a lot depending on the seat. And the reason is that our dataset, test dataset consists only of 9 patients, so it's rather small. So in some cases, our precision is 100%, in some cases, it's 50%, and in others below that. And here's aggregated RLC curve, and we got area under the curve around 0.7. And our conclusions, the most important predictors for patient death are multi-organ failure, anisocrea, volatility of pressure reactivity index, arterial blood pressure, and also in other seats we could see that it was white blood cell count, non-reactive pupils, a marked category, and root mean square of successive differences. And Based on that, machine learning approach reveals predictive significance of both neuromonitoring parameters and biochemical metrics in mortality prediction. And obviously, further research involving a larger patient cohort and comparison with other machine learning models is necessary to validate our findings. And this is all.
Thank you very much for your presentation. And now it's time to start the discussion.
Could you please tell us what was the source of the patient's data? What's the hospital-based study? Or
Yes, that's from the Wrocław Hospital.
so these were like patients additionally admitted to the hospital into the whole base. It was like within 1 year or more years of gathering data.
I don't know that exactly from what period of time. I know this all the data comes from the one hospital.
Thank you.
And can you tell us what is your contribution to the work?
So contribution of my friend was to preprocess data. My contribution was to learn fit the machine learning algorithm and take the conclusions. And also perform the explainable artificial analysis.
Could you tell us about the what kind of brain injuries were evaluated in this group of patients? Do you know about the history? Because my question is related with very important input into your results, because some kinds of brain injuries are importantly related with some output. You know what I mean. So I would like to know what kind of brain injuries were evaluated in this group of patients.
So we had different routes of the brain injuries, but I don't honestly I don't remember all of them. It was many different ones.
Because in my opinion, it is very important to present these results according kind of brain injuries. So maybe in future, could you please add it as a demographic characteristic and more not only demographic, but medical evaluation, and also to try to input in statistical analysis and maybe for searching for some results also very important in this kind of work. And also I have a question to you about your opinion why anisocoria was one of the important predictors of death, as you mentioned before. What is your opinion about it?
Opinion in what?
About relation with anisocoria and death probability, because as we can see on your conclusion slide, anisocoria was one of the most important predictors of death. And I would like to ask you about your opinion, why this parameter is so important.
Well, the importance of this parameter comes from the SHAP analysis of our model. So, and this is what the model based its decision on. So it's not my individual opinion that it is important, but
I would like to ask, because when we are preparing some study, we would like to know what the results are important for us. clinicians and for others experts. And I would like, because we as a neurologists and also neurosurgeons very often evaluate anisocoria. It is very important sign for us and also for the patient state. And when you prepare these results, and not only results, but also conclusions, you should know what it means, why this anisocoria it would be so important. So the importance of clinical and statistical relation is very important to present this study.
So it's obviously correlated with the autonomous nervous system, but
it is related with strength of the brain injury in general way. So it is, I think, important topic for improve in your further studies. But think about it, because it is very important to link between neurological signs and statistical results. Thank you.
thank you.
Thank you for the questions and for your presentation.
Thank you.
Now the presentation, the role of selected neurodegeneration, inflammatory and signaling parameters in the pathogenesis of MS.
Good morning. My name is Piotr Lechoński, and I will be presenting our study about multiple sclerosis. So, at the beginning, a few words about multiple sclerosis. It's a chronic autoimmune disease characterized by neurodegeneration and neuroinflammation. In Poland, we have 55,000 people with MS. Women get MS twice as often as a man. And we have different types of MS: relapsing remitting, secondary and primary progressive, and rapidly evolving severe multiple sclerosis. So, what was the aim of our study? Our study aimed to assess the levels of selected neurodegeneration, inflammatory and signaling parameters in the cerebrospinal fluid of patients diagnosed with relapsing remitting multiple sclerosis, diagnosed de novo. Next point, materials and methods. So in this study took part 62 patients diagnosed with RRMS de novo, and 24 people were in control group. So at the beginning, we measured concentrations of markers from CSF. Then we analyzed presence of MRI lesions, gender, comorbidities. We analyze correlations between these parameters, and then we choose the most significant. And to measure levels of markers, we used two panels. First one, human neuroscience panel 18-plex, Bioplex Pro Human Cytokine 27-plex. And these panels allowed us to measure a lot of markers. The most significant are on this slide, but to simplify them, I put them into three groups. The first one, yellow, neurodegeneration markers. Second one, neuroprotection markers, blue, and neuroinflammation markers, red. Next point, results. First result, significantly higher concentration of GFAP and NFH in the RRMS group. Many studies suggest that GFAP and NFH could be used as prognostic biomarkers and to monitor the effectiveness of therapy in MS. And also GFAP could help differentiate RRMS and PMS. Second result, decreasing the number of T2 lesions in an MRI with increase in BDNF and FGF21. This positive correlation of these markers levels with reduction in the number of T2 lesions on MRI images suggests that they may influence repair and regeneration processes in MS patients. Significantly higher concentrations of GDNF, tau proteins, BDNF, S100B, and NFH in men, and significantly higher neurogranin in women group. And this suggests that this different levels, depending on gender, suggest that pathogenesis of multiple sclerosis has different pathogenesis depending on the gender. And finally, positive correlation between interleukins important for MS pathogenesis and markers such as NCAM1, tau protein, and BDNF. There are studies suggesting that pro-inflammatory cytokines may affect the expression of NCAM1 on the surface of cells, for example, NK cells, which may increase the ability to adhere to target cells and infiltrate into nerve tissue. The positive correlation between interleukin 70A, interleukin 12, and tau protein suggests that inflammatory processes are correlated with neurodegeneration processes. And the positive correlation between interleukin 70A and BDNF levels suggest that although interleukin 17A may induce inflammatory and damage neurons in MS, neuroprotective mechanisms such as BDNF production may also be activated, which may act to protect neurons from damage. So, what are the conclusions of our important? GFAP and NFH have the potential of to serve as prognostic biomarkers and to monitor the effectiveness of therapy in MS. And also GFAP can help differentiate RRMS and PMS. And BDNF and FGF21 may positively influence repair and regeneration processes in MS patients. Thank you for your attention. It will be a pleasure to answer your questions.
Thank you for the presentation.
Thank you for your presentation. I would ask you, in your opinion, which of the analyzed parameters would be the most useful in multiple sclerosis diagnosis, in your opinion?
In my opinion, the most useful could be GFAP and NFH because there are many studies that also achieve this result. But I'd also want to add that many studies did measure NFL levels, but NFL levels are there is correlation between NFL and NFH levels.
I want to really congratulate you the results of this work. It is really a very novelty field in MS area, and I would like ask you, because you cooperated in this project with very experienced tutors, Dr. Bożena and Dr. Natalia. What was your role in this investigation?
My role was to make research, to search for bibliography, to help with analyzing statistics and results, and I made this presentation.
I invite you to further work. Thank you.
Congratulations on your work. I have several questions. Could you explain the source of the control group? Because you did the lumbar puncture, you did the MRI. What kind of patients they were?
So the control group was a patient that we have the data. Our database is based on patients which went to Zabrze clinic in purpose to diagnose, and control group was the group group without MS, diagnosed without diagnosed MS after lumbar puncture. So every patient that is in our database had performed lumbar puncture, and we put to study group patients that meet McDonald's criteria, and to the other group, to the control group, we put patients that doesn't meet McDonald's criteria.
Those patients in the control group, they had any other neurological diagnosis, or they are otherwise healthy?
Probably yes, because they went to probably no, sorry, I probably no, because we because they had no effect on the levels of neurodegeneration parameters in CSF. So
my second question is, you did lots of evaluations, lots of lab tests. What was the founding source? Because probably it's cost some.
Founding source. It's a difficult question for me because I'm only on student level. So it's not a question for
forget it, this question. My final one is, you showed that the BDNF level was much higher in men than in women. Do you have an explanation for this?
Excuse me, can you ask?
BDNF, the neurotrophin level, was higher in men compared to women.
And we see this in statistics that women get MS more often than men, and this BDNF is it's a neuroprotection marker. So probably this helps to this helps men to not get MS.
They were diagnosed with MS, right? It leads to another question: why the BDNF level was so high? Okay, if we need to start.
Thank you very much for the questions and for the presentation.
Thank you very much.
The next presentation will be clinical differences in multiple sclerosis patients based on age of onset.
So good morning, everybody. My name is Magdalena Reslik, and I would like to present our work to you. It was clinical differences in multiple sclerosis patients based on age of onset. So, first of all, I would like to tell what multiple sclerosis is. It's an inflammatory demyelinating condition that results from an autoimmune attack of myelin, the fatty insulation that surrounds the nerves in the brain and spinal cord. This disrupts the electrical impulses that are sent through the nerves to the rest of the body and results in scars, plaques, or sclerosis. At the figure are presented symptoms of multiple sclerosis. And moving on to the epidemiology, I would like to point out that over 1.8 million patients worldwide have MS, and in Poland, over 54,000 people has MS. And in Poland, a woman has MS twice as often as men. And morbidity rate in Poland is 14.4 per 10,000. And average manifestation age is from mid-20s to early 40s. And moving on to the essence of my presentation, I would like to tell about the aim of our study. The aim of the study is to compare differences in the clinical course, disease severity, and treatment of multiple sclerosis between different age groups. And moving on to the materials and methods, it was a population-based retrospective cohort study. We analyzed data came from the period of time between April 2018 and July 2023. And we analyzed data from 443 patients. They were in the range of age from 18 to 80. And we analyzed this data using Statistica and Microsoft Excel. And what data we collected? We collected age and gender distribution of patients, type of multiple sclerosis in every age group, age of multiple sclerosis diagnosis in each group, mean multiple sclerosis duration time in years, EDSS during the last examination in hospital, switching of disease-modifying therapy medication in patients, and also most common comorbidities in this group of patients. And moving on to the results, I would like to show you the percentage and gender distribution of patients in each group. So in the youngest group of patients, over 68% were women. In the middle group, over 75% were women. And in the oldest group, over 86% of patients were men. Let's talk about type of multiple sclerosis in every age group. So in the youngest group of patients, over 91% of patients has relapsing remitting multiple sclerosis. In the middle group, also over 80% of patients has relapsing remitting multiple sclerosis. And I would like to point out that in the oldest group, SPMS and PPMS were more often than in the younger groups. Let's talk about mean multiple sclerosis duration time in years. So in the youngest group, it was over 11. In the middle age group, it was almost 11. And in the oldest group, it was over 7.5. Overall, EDSS score during the last examination in hospital was 2.5 in the youngest group, 3.3 in the middle group, and 4.3 in the oldest group. So we can see that it drops with age in the youngest group of patients. And let's move on to the adjustments in the DMT medication patients in each group. So I would like to point out that in the oldest group of patients, over 70% of patients have never changed their medication. And in the youngest group of patients, only over 37% of patients have never changed their medication. The most common comorbidities in each group. So the most common comorbidity in each age group was hypertension. The second place was dyslipidemia and degenerative spine disease. And in the oldest group of patients, over 27% of patients had hypertension. And so let's move on to the conclusions of our study. Female patients represent majority in the youngest group and in the middle group of age. Men constitute a majority of patients in the oldest group of patients. Patients with multiple sclerosis over 49 years of age, so in the oldest group of patients, more often have PPMS and SPMS compared to younger groups. while relapsing remitting is most prevalent in youngest group. EDSS score during the last hospital appointment is highest in the oldest group, and tendency to change DMT medication is highest in the group of 18-31. Drops with patient's age. Patients in the oldest group tend to be most often burdened with comorbidities in comparison to younger groups. Thank you for your attention. I will be glad to answer your questions.
Thank you for the presentation.
Thank you for your presentation. I have some questions. First of all, I would like to ask you about the novelty of this project, because when we prepare some study, science study, we should improve the science. What is your point of view about novelty of this study?
So I would like to tell about the age groups, because we divided our patients into 3 groups depending on the age, but this age was, in our opinion, divided like the needs of the patients. So we would like to see what comorbidities will be in the group of patients according to this age, and the EDSS score in these groups, because I want to tell about late onset multiple sclerosis. It is diagnosed over 50 years old, but the group in our patients were too small, so we decided to divide groups into 31 and over 49 years old, and it was also to see the statistically significant results.
In my opinion, I can't see any novelty in these results. And my second question is about the older group, oldest group, as you presented us. You have shown that more than 80% of cases are men.
Yeah.
What is why exactly? Because we can see it in our clinical practice, really, and we have a great experience in this area. And maybe you have some knowledge about this and compare, and please maybe compare it with some publications. Please tell us about it.
Yes. We also see this difference in the percentage, and it's due to the that only 20% of 20 people were in this group of patients. So we did the research about that, and we found out in some studies that in PPMS, in the oldest group of patients, there are more men than women. It was some researches like that. With PPMS and SPMS in the oldest group of patients that were.
It is well known about the phenotypes, but I can't agree with this result, because it isn't true that about 80% of patients in group, in oldest group, more than 50, is represented by men. Thank you.
Thank you.
Thank you for great presentation. I have one question. Did you compare the first symptoms of the disease between these 3 age groups or not?
We tried to, but we didn't did that because of lack of the data in our database. So we didn't did that because the statistics will not be significant. So we rejected that data.
Thank you very much for the questions and for your presentation. We can move on to the presentation, suspected optic neuritis at the ophthalmological emergency department.
Okay, so good day, everyone. My name is Anton Shenko, and we're very grateful and amazed to be able to present you our newest study, which is suspected optic neuritis at the Ophthalmological Emergency Department. So what is optic neuritis? It is a demyelinating inflammation of the optic nerve. There is, of course, a wide spectrum of non-specific symptoms, but there is a saying, which most of us probably know, telling us that when we are dealing with optic neuritis, neither the patient nor the ophthalmologist can see anything. And this did not come from nowhere. In fact, in most cases of optic neuritis, we can observe a normal retina and optic disc image in the examination of the eye's fundus. The etiology of this disease is diverse, ranging from multiple sclerosis, of course, and other autoimmune disorders, ending with even infectious agents, quite often actually idiopathic causes. The median age of patients is 24 to 45 years. Importantly, women suffer from this disease more than twice as often as men, and it often affects Caucasian people living in a temperate climate. So what was the aim of our study? To assess the effectiveness of the early stages of optic neuritis diagnosis process, giving a closer look at the most common and most important signs and symptoms occurring while facing this entity in the emergency room conditions. How did we do the research? So for several months, we've been consistently gathering data on the patients with optic neuritis suspicion from the Katowice University Clinical Center archives here in Katowice. And the result of our work was the collection of the following data. In the period from January to June 2022, we retrospectively analyzed 71 information cards of the ER. Women reported more often compared to men. The median age was 37 years for women and 34 for men. And first-time patients accounted for 48 cases, returning ones for 22. Here we present the data on the appearance of typical symptoms of patients with the initial optic neuritis suspicion in the emergency room conditions. So the presence of one of the typical optic neuritis symptoms, pain with the eye movement, was demonstrated by approximately 17% of the people solely. Then we have another crucial symptom, color vision disorders, in total of over 62% of the patients. And then we have these two symptoms combined, to be accurate, 20.7% in total, and these were women only. 11 patients were admitted to the hospital ward for further diagnosis. And of the 11 hospitalized patients, 4 were diagnosed with definite and confirmed optic neuritis. The remaining diagnoses were ischemic optic neuropathy and uveitis. And differential diagnosis of these three entities, a trivial problem or a significant diagnostic challenge. So in the table, we present a short comparison of these three entities, giving a closer look at both differences in diagnostic tests as well as the symptoms. Starting with pain with the eye movements, this is an element that, especially combined with the rest of the clinical picture, may really help us facilitate diagnosis. Moving to lack of optic disc swelling, also could suggest at least a typical form of optic neuritis. Then moving on to the differences in the diagnostic tests. The demyelinating MRI changes, suspicious OCT results could also help us differentiate optic neuritis from these other two entities. And in this section of the presentation, we'd like to introduce you to 4 short case reports of the patient with diagnosed confirmed optic neuritis. So the first one was a 17-year-old female presented to the ER one day after the symptoms onset, which were, as we can see, typical ones. Visual acuity disturbances in the left eye, pain with the eye movements, color vision disorders. The patient had been diagnosed with specified demyelinating lesions in the past. So she underwent visual field examination, macular OCT, VEP pattern, and MRI, which showed demyelinating lesions located both supra and infratentorially. Implemented treatment was methylprednisolone, dexamethasone, diclofenac, resulting in clinical condition improvement. Then we have an 11-year-old boy, also reported one day after the symptoms onset, typical symptoms as well. He underwent macular OCT and VEP flash in the left eye, which showed an increase in P2 latency up to 10% compared to the norm, and this alone could suggest optic neuritis. Then we have a treatment which resulted in also gradual improvement in clinical condition. Case 3 is a 35-year-old male who reported to the ER 2 days after the onset of the symptoms, and the attention was drawn the HPC to the ongoing multiple sclerosis diagnosis process. The patient's visual field had been examined. He also underwent VEP MRI, which showed the presence of lesions located supra-infratentorially, typical of the primary demyelinating process. So systemic treatment, which was no different than the previous ones, methylprednisolone, diclofenac, dexamethasone, also resulted in clinical condition improvement. Finally, we have same situation as previously, 31-year-old patient, female this time, reported on the same day as the symptoms occurred. Typical, of course. Same diagnostic tests were ordered, and she also presented demyelinating changes in the white matter located supratentorially. Left optic nerve showing crisis signal intensity. Treatment helped to improve clinical condition. To what conclusions have we reached? The most common symptoms were decreased visual acuity, color vision disorders, and pain with the eye movement. The patients largely suffered from loss of the central visual field. The most sensitive and specific test was MRI, which played a key role in the final diagnosis. In 3 out of 4 patients, MRI showed changes typical of the ongoing demyelinating process. The time of patients reporting for ER was important for the effectiveness of the therapy and further prognosis, and the therapy using methylprednisolone brought significant improvement in the clinical condition of patients. And the short comparison of these two entities, optic neuritis, multiple sclerosis, this is often the first manifestation of MS, and it develops approximately in 20 to 50% of patients with previous optic neuritis, though we must remember that correlation does not equal causation. As we have already mentioned, the etiology of optic neuritis is so broad that we cannot link these two entities by a clear cause and effect relationship. And moving on to the take-home message, optic neuritis is a disease with diverse etiology and cause, and in the light of developing diagnostic methods, it still poses a challenge to the correct diagnosis and treatment. Thank you for your attention.
Thank you for the presentation.
Thank you for your show. I would like to congratulate you the presentation and also the topic. I want to ask you about the time about performing MRI in these cases. Do you know when the MRI, brain MRI mainly, test was performed? I would like to ask about relation with methylprednisolone treatment.
Some of the patients had been already diagnosed with the multiple sclerosis in the past. And
it will be the second question. Thank you.
And, the remaining ones were diagnosed after being admitted to the hospital ward. Then they have done, of course, an MRI, if MRI indicates the demyelinating process, then methylprednisolone is applied. And yeah.
Why is the question performed? Because it is a strict relation, because MRI gadolinium enhancement brain or spine in MRI test and treatment with steroids. We always perform this test before treatment with steroids, with methylprednisolone. That is very, very important for evaluation the active lesions. And I would like also ask you as an ophthalmologist or father ophthalmologist. And about the second issue, I understand that do you evaluate the final diagnosis in these cases? It is mainly related with multiple sclerosis diagnosis. Am I right?
In these cases, because there were finally 4 patients diagnosed with optic neuritis, so in 3 out of 4 of these cases, there were significant lesions visible in the MRI.
Thank you. Good job.
Thank you for a very interesting presentation. I have one question. According to your knowledge, what is the percent of the autoimmune optic neuritis compared to infectious or systemic optic neuritis?
Overall, the big majority of the optic neuritis incidence is of the autoimmune etiology. And I think our study shows that. Most of the patients have the typical form of optic neuritis, which has the autoimmune kind of etiology, and the other etiologies like infectious agents or idiopathic causes and different ones are I think they are a lot. They are happening rarely, not as quite as often as the autoimmune disorder.
Okay, thank you.
Just the final one question. What was your personal input to the study?
So I've personally helped to, of course, starting with, I've helped to gather the necessary data in the UCC archives. Then my contribution was to the process of creating the study itself. searching for similar publications in the PubMed and comparing it to what we have found. So yes, that was it.
Thank you for the questions and for your presentation. And now the presentation, Alternating Hemiplegia of Childhood, a single center study.
Good morning, my name is Malwina Brzozowska, and today I will present to you a single-center study about alternating hemiplegia of childhood. First described in 1971, alternating hemiplegia of childhood is a rare, severe neurodevelopmental disorder with infantile onset recurrent episodes of hemiplegia in either side of the body, emerging in the first 18 months of life. The prevalence of AHC is estimated at 1 in 1 million children, and in 2012, de novo pathogenic mutations in the ATP1A3 gene have been linked with the disease pathology. AHC is characterized by recurrent site-alternating paroxysmal episodes of hemiplegia, typically triggered by emotional or environmental factors such as exercise, exposure to light, specific foods, sounds, or hot water, while symptoms are relieved by sleep and post-awakening periods. Beyond paroxysmal manifestations, AHC may include persistent indirect neurological abnormalities whose prevalence increases with age, developmental issues such as speech and language delay, cognitive deficits, and behavioral problems with various degrees of severity are the most common findings, followed by dysarthria, ataxia, chorea, and less frequently pyramidal drug signs. Currently, there is no single standard treatment for AHC. Flunarizine and topiramate are most commonly used to manage the course of the disease and severity of symptoms. Previous studies have shown that the use of benzodiazepines, vagus nerve stimulators, and ketogenic diet, among others, may prove beneficial to patients. Various abnormal ocular movements are specific to AHC and may function as a diagnostic clue. The aim of our study is to analyze the course of the disease and genetic mutations in patients with AHC. In order to achieve that, we gathered medical history of 7 patients, 2 male and 5 female, with the diagnosis of alternating hemiplegia of childhood that were hospitalized at Pediatric Neurology Department of Medical University of Silesia in Katowice. We analyzed data that included family history, gestation and delivery period, psychomotor development, course of treatment, age at onset, and results of genetic testing. I will present the results on following slides. Results have shown that the age of at onset in all of our patients was lower than 15 months. Age of diagnosis differs, but patients who got the AHC diagnosis at the age of 10 and 12 were the oldest, implying that it could be the result of development in the field of genetic research. Most of our patients' family histories were not remarkable. The gestation and delivery period also showed no significant correlations. 2 patients have coexisting epilepsy, and also 2 patients at some point received epilepsy treatment, but the diagnosis was later changed. 3 patients received flunarizine as their treatment, and magnetic resonance imaging revealed abnormalities in only 2 of the patients' nervous systems. Abnormal activity was observed in 4 patients' EEG. However, patient 2 is diagnosed with epilepsy, so the EEG findings may be caused by either of the diseases. Only 1 of the patients displayed age-appropriate motor development. However, all of the children have intellectual disabilities. 3 of the patients haven't started walking to date, and 4 have impaired communication skills, communicating their needs with single words and finger pointing. We analyzed our patients' mutations in ClinVar, a public archive of reports of the relationships among human variations and phenotypes, and found 4 of the mutations to be pathogenic, 1 likely pathogenic, and 1 of unknown significance. On this slide, you can see precise mutations of our patients, and only 2 patients shared the same mutation, that is patient 2 and patient 4. However, the course of the disease differed among them. Their age at onset was different, and patient 2 is having coexisting epilepsy, while patient 4 was never treated or diagnosed with epilepsy. To sum up the results, the first symptoms of all of our patients emerged in the first 15 months of their lives. 6 out of 7 patients had delayed psychomotor development, as well as 6 of them presenting pathogenic or likely pathogenic mutations. 5 out of 7 had normal MRI findings. Lastly, 4 of 7 patients at some point were treated with for epilepsy, with 2 patients still diagnosed with epilepsy alongside AHC. And here is how our results compare with previous studies in the field of alternating hemiplegia of childhood. Age at onset in our patients was consistent with other studies. Studies on bigger groups showed that up to 63% of patients with alternating hemiplegia of childhood has coexisting epilepsy. However, only 2 of our patients has coexisting epilepsy. Currently, cerebellum atrophy in MRI is being investigated as potential biomarker for AHC, and 1 of our patients had discrete cortical atrophy of the brain and cerebellum. Nonetheless, 5 of our patients had normal MRI findings. The majority of our patients had delayed psychomotor development, and studies on bigger groups showed the same results. So, as to summarize, having analyzed our patient data, the conclusion comes to mind that alternating hemiplegia of childhood poses a diagnostic challenge. Due to a vast variety of symptoms similar to other diseases such as epilepsy, genetic testing, however, plays a crucial role in making the differential diagnosis. Thank you for your attention. Here are our resources. And should you have any questions, feel free to ask.
Thank you for the presentation.
Thank you for your presentation, very interesting. I would like to ask you about your opinion about the differences in the results related with coexisting epilepsy. In your study, do you observe only 2 cases with coexisting epilepsy, and in comparing studies, more than 60%? What is your opinion about the differences?
Also find it interesting, and so interesting that we contacted the Polish AHC associations in order to gather a bigger group of patients and analyze on bigger group of Polish children. Maybe then the different coexisting epilepsy percent will be similar to other studies, because 7 patients is big group for rare neurodevelopmental disorder, but small for having doing statistical analysis.
Thank you.
This is a genetic disorders. Are there any gender specifics? Because in your group, 5 patients out of 7 were female.
Yes, but on bigger groups, we didn't see the same correlations.
And you also showed that the MRI could help with the diagnosis. Could you tell us what are the specific changes for this disease in the MRI?
The atrophy and the cerebellum, but the studies I read on this topic were new and on smaller groups, but it can be a potential biomarker, but it must be investigated further.
Is it reasonable to make another MRI since the first one come with no clue?
Yes, because I've also come to the conclusion that maybe it's because of the progression of the disease, and in further studies, I would like to read more about the time difference between first MRI and second, and maybe there are changes on how the disease progresses.
Thank you very much.
Maybe Dr. Sylwia Pyrtek has some question.
Now I have no question. Thank you.
Okay, thank you. So if there are no more questions, thank you for questions, for discussion, and for your presentation. The next presentation is analysis of brain injury parameters and CSF interleukins in de novo RRMS patients versus controls.
Welcome everyone present. My name is Urszula Majda, and it is my honor to present you our study titled Welcome everyone present. My name is Urszula Majda, and it is my honor to present you our study titled Analysis of Brain Injury Parameters and Cerebrospinal Fluid Interleukins in de novo relapsing remitting multiple sclerosis patients versus controls. Multiple sclerosis is a chronic, inflammatory, and demyelinating disease of the central nervous system. Its non-specific early symptoms cause many diagnostic challenges. It is also a leading non-traumatic cause of disability among young adults. Globally, but also in Poland, we observe an increase in the number of cases of multiple sclerosis. In Poland, there are over 55,000 affected individuals. The disease is characterized by an imbalance between damage, repair, and functional reserve of the brain. The main factors leading to brain damage are chronic inflammation and neurodegeneration. In our study, we have identified some factors that play a major role in these processes. Heavy neurofilaments and glial fibrillary acidic protein are involved in neurodegeneration, while S100B and ubiquitin C-terminal hydrolase L1 dominate in chronic inflammation. The aim of our study was to assess the concentration of selected parameters of brain damage, NFH, GFAP, S100B, and UCHL1, and selected cytokines in cerebrospinal fluid in patients diagnosed with de novo relapsing remitting multiple sclerosis compared to healthy controls. We enrolled 101 patients with de novo relapsing remitting multiple sclerosis. 72% were women and 28% were men. The median age was 38 and 4 years. Among these participants, the main symptoms included vision disorders, vertigo, balance disorders, weakness of limbs, sensory disturbances, and optic neuritis. We also enrolled 75 healthy controls. 85% were women and 15% were men. The median age was similar to the previous group. It was 38 and 8 years. In this group, main symptoms included vertigo and headaches, and in this group, demyelation was excluded. We determined the parameters of brain injury. NFH, GFAP, S100B, and UCHL1. We also assessed the levels of selected cytokines. Statistical analysis was performed using Statistica data miner. Moving on to results and conclusions. The concentrations of GFAP and NFH in the cerebrospinal fluid were higher in the study group compared to the control group, while the concentration of UCHL1 was lower in the study group. The concentration of S100B did not differ between the groups. In patients diagnosed with RRMS, the concentration of GFAP correlated positively with the concentration of interleukin-8. The level of NFH increased with the concentrations of TNF-alpha, interleukin-7, and interleukin-10. UCHL1 correlated positively with interleukin-2 and interleukin-3. In the control group, the concentration of NFH correlated positively with the concentrations of interleukin-6 and interleukin-8. The level of S100B increased with the concentrations of interferon gamma, interleukin 5, interleukin 6, interleukin 7, interleukin 8, and interleukin 9. In the study group, the concentrations of GFAP and NFH were higher in the group of patients with gadolinium-enhancing lesions on MRI compared to the group of patients with no gadolinium-enhancing lesions on MRI. Also in the study group, time from the first symptoms to diagnosis correlated positively with the concentrations of interferon gamma and TNF-alpha, also interleukin 1, interleukin 4, interleukin 5, interleukin 9, and interleukin 10. I would like to emphasize that our findings suggest that NFH and GFAP in particular may be useful biomarkers in early stage of RRMS. Although the roles of these biomarkers in RRMS are promising, further research are necessary to fully understand their potential clinical utility. Finally, I would like to refer to the literature data. Increased NFH concentrations were noted in patients with 5-year RRMS evolution. Correlation between NFH levels and disease progression was observed. NFH levels were significantly higher in the relapsing group compared to the remitting group. A significant correlation was observed between GFAP levels and gadolinium-enhancing lesions on MRI. Higher levels of GFAP in the cerebrospinal fluid of patients with RRMS were associated with an increased risk of disease progression. Higher levels of GFAP were present in patients with primary progressive multiple sclerosis compared to relapsing remitting multiple sclerosis patients, which can be a topic to further research. UCHL1 was identified as a marker with the highest diagnostic sensitivity compared to other markers. And studies showed increased S100B levels in the cerebrospinal fluid of patients with multiple sclerosis, which differs from the result of our study where the concentration was similar to the control group. This is my bibliography, and I want to thank you so much for your attention. Feel free to ask me a question.
Thank you very much.
Thank you for your presentation. You have presented us the very important and very novel topic in MS field. I would like ask you about your opinion about the clinical importance of your results presented by you in our everyday clinical practice. What do you think? Why it is so important to have some biomarkers in everyday using in MS clinical practice?
So I think that this is important because, like I said at the beginning of my presentation, multiple sclerosis has early non-specific symptoms. So I think finding these biomarkers it will be easier to diagnose multiple sclerosis in early stages. It will be also good for patients because when they have non-specific symptoms, they know that something is going on in their organism, but they don't know why, and it could be just frustrating for them. So yeah, I think the most important is that we, thanks to this biomarker, we could diagnose multiple sclerosis earlier and treat it earlier, but it also further research are still very important and necessary.
Thank you. I fully agree. We know that up to date we don't have practical biomarkers in MS field. We don't have biomarkers specific for diagnosis MS, for differentiating between phenotypes, and also we don't have biomarkers for evaluating the treatment effectiveness. So we need this work, and I would like to thank you for participation. Thank you.
Thank you so much.
You did a very nice study about the biomarkers. Did you do any comparison and analysis? Those patients, if I understand right, those were coming to the clinic for the first diagnosis of MS,
yeah,
but they probably had some history of any relapses of any focal signs. Did you do any comparison between the levels of the biomarkers that you assessed and the clinical presentation at the day of the assessment?
No. In the study group, one of exclusion criteria was experiencing disease relapse. So the study group involved only patients with with diagnosed de novo RRMS.
So if I understand right, at the time of your assessment, those patients were symptoms-free.
Yeah.
Very fast question because our time is over.
Okay, according to our knowledge, the concentration of the protein S100B is higher in relapsing remitting multiple sclerosis patients compared to healthy controls, but not their study. And my question is why? Have you got any idea?
Yeah, I think it could be. I think it could be a reason of method of analysis, or maybe the storage of our samples. But primarily, I think it could be the number of patients in the study group, and also the selection of the study group in studies I showed earlier. Were included patients with, for example, primary progressive multiple sclerosis. We only study relapsing remitting multiple sclerosis, so I think it could be a reason also.
Thank you for the discussion, for your presentation.
Thank you so much.
The next presentation is association between MRI findings and cognitive changes following deep brain stimulation in Parkinson's disease. And this work will be presented online by Karolina Szałata. Could you share your presentation with us?
Sure. I thought it will be shared from there, but
we don't see it still.
Okay.
Okay. We see you. Could you set it in the full? Okay.
Yes.
Thank you.
You hear me and see everything?
Yeah, we see you, we hear you. You're good to go.
Okay, great. So today I will be talking about the research that was exploring the potential of brain imaging to predict cognitive decline in Parkinson's disease patients after deep brain stimulation. And Parkinson's disease often presents with debilitating tremor, rigidity, and slowness of movement. And deep brain stimulation has emerged as a promising treatment in advanced cases. However, previous studies suggest that deep brain stimulation may lead to cognitive decline in some patients, affecting attention, memory, and thinking skills. And this raises a crucial question. Can we predict which patients might experience that cognitive decline? And can we identify markers that help us make informed treatment decisions? And in our study, we tried to answer these questions. We focus on Parkinson's disease patients who received DBS targeting subthalamic nucleus in our hospital. And from this pool, we identified 38 patients with complete data, including pre- and post-operative cognitive assessment and preoperative MRIs of the brain. And as you can see from the table, our study group consisted of individuals with a median age of 54 years, and majority of them reporting male gender. To assess Parkinsonian symptoms, we use Unified Parkinson's Disease Rating Scale, UPRDS, and to quantify medication use, we used cumulative L-DOPA equivalent daily dose. Then to divide patients into decline and stable group in every test, we used reliable change index, and to analyze difference between pre- and post-operative score in clinical and neuropsychological data, we use non-parametric tests. It's Wilcoxon tests. To assess association between that change of psychological examination and MRI parameters, we utilized Spearman's correlation. And at the end, we employed logistic regression model for every test. To obtain our MRI parameters, we measured manually MRIs and we selected structures based on the literature review. So on these pictures, you can see how we measured some of the structures. And our study shown that patients experience motor improvement as assessed by increase in UPRDS score. Also, they experience reduction of medication. It was dopaminergic medication. But despite that motor improvements, score in some of the tests declined after the surgery, for example, mini-mental state examination. And our correlation analysis revealed that score in some tests, like change of the score in some tests, correlated significantly with our parameters, mainly with cortical folding measures. For example, width of singularity gyrus, precentral gyrus, insular cortex, or frontal gyri, but also lentiform nucleus and lateral ventricle, and also it correlated with some of our demographical and clinical data, as you can see on the right. And notably, right lentiform nucleus was significantly correlated with the performance in Tower of London test, even after adjustment for multiple comparisons. And also in logistic regression model for Tower of London test, it remains a significant factor, which might suggest that longer lentiform nucleus is associated with the worse performance in Tower of London test after the surgery. And on the right, you can see distribution of this parameter among declined and stable patients in TOL test. And previous studies suggested that anatomical parameters such as thickness of frontal and temporoparietal cortices and volume of some of the structures such as hippocampus, the amygdala, and the nucleus accumbens might be predictors of cognitive decline in Parkinson's disease. And our study shown that additional anatomical parameters can be useful, such as cortical folding measures and lentiform nucleus length. However, our study has some limitations. For example, small sample size and retrospective data collection, and they should be addressed in future studies to strengthen the generalizability of our findings. So, in conclusion, we have we found anatomical factors that may potentially serve as the predictors of cognitive decline in some of the domains after deep brain surgery. Also, we found that other anatomical factors, not only volume of structures, but maybe morphology, for example, length of the nucleus, might be also useful and worth studying in future research. And it's important to make that research because by deepening our understanding of cognitive alternations after DBS, we can pave the way for more personalized treatment approaches that prioritize both motor and cognitive well-being in Parkinson's disease. Thank you, and you can write me an email if you have additional questions.
Thank you for the presentation. It comes for the question from our committee.
Thank you very much for your presentation. I would like just only add one comment. I want to congratulate you. The topic, it is very important in neurology field. So I want to congratulate you and your tutors. And also I want to notice that you observe some limitation of the study. It is very important, and it is related with your science evidence. So thank you for these issues.
Thank you very much.
Can I ask you, when did you perform the MMS examination? How long after the DBS procedure?
We had examination retrospectively collected, and most of the tests were performed between 6 to 18 months after the DBS. So there were examinations from the data set.
Okay, thank you. And what was your influence on creating this work?
I made most of the work because I analyzed the data by myself and also made a literature review. And my colleagues helped me with a collection of data and part of the measurements of MRIs.
I have two more questions. Congratulations on your work. Maybe I missed it in your presentation. All those patients were after the bilateral DBS?
No, I had a table and 30 of the patients had bilateral DBS and 8 of them had unilateral. And I used it as confounding factor also in logistic regression and in correlation.
Okay, thank you. And the other question is, the MRI that you showed, the MRI was performed before the DBS or after?
Yes, before, because it's like our goal was to check if MRIs taken before the DBS can help us to predict the outcome.
Okay, thank you.
Thank you.
I would like, if I could, some questions about the methodological aspects. Okay. You perform neuropsychological assessment, and I would like to ask about the adult intelligence scale. Why did you use this test in your study? Quite complex and to measure intelligence.
Actually, we had data that was used clinically for assessment of patients. So we haven't decided what data we will take. We had just evaluation of patients, and psychological tests were decided by psychologists who made them. So we used that test that were used clinically. We haven't checked.
Okay, I understand. And my second question is about the Tower of London. Do we have the Polish adaptation of this test? I suppose that rather not.
I think it should be a Polish version because psychologists used it in Polish patients. I haven't made that test, so I don't know how it looks practically. We only had evaluation of psychologists to use. So we haven't decided that they use this test.
I ask about the Polish adaptation because it's we have problem in Poland with different tests. So your opinion is that we have official Polish adaptation, yeah?
Yeah, actually, I'm not sure because I don't know specifics about the psychological examination. We were given the scores that patients were gained after the examination of experienced neuropsychologists. So we use it we used prepared data that were used in clinical assessment. So yeah, unluckily, I'm not sure how does it look practically, how they do that test in the clinic.
Okay, thank you. Thank you very much.
Thank you for your presentations and for the discussion from our committee. Thank you very much. The next presentation is the co-occurrence of autoimmune diseases and multiple sclerosis, a retrospective study.
Nie ta prezentacja.
Honorable jury, ladies and gentlemen, my name is Olga Falger and I would like to present our study regarding the co-occurrence of autoimmune diseases and multiple sclerosis. I would start by briefly explaining what multiple sclerosis is. Then I would like to present the aim of our study, as well as materials and methods that have been used to carry it out. In the next section, I will share the results and the conclusions that arise from them. So without further delay, multiple sclerosis is a demyelinating disease of a central nervous system. It is an autoimmune disease that results from complex interactions between genetic and environmental factors. As with other autoimmune diseases, it is more common in females with a peak incidence in the ages between 20 and 40. We have three main clinical forms of MS, which is relapsing remitting form of multiple sclerosis, primary progressive form of multiple sclerosis, and secondary progressive form. The fact that multiple sclerosis shares susceptibility genes with other autoimmune diseases raises the question of whether it is associated with a higher incidence of those diseases than in general population. Autoimmune diseases are caused by abnormal humoral and cellular responses to one's own antigens. This can lead to the co-occurrence of different autoimmune diseases in the same patient. So, the aim of our study was to determine the prevalence of coexisting autoimmune diseases among patients diagnosed with multiple sclerosis. Our study is a retrospective analysis that covers patients diagnosed with multiple sclerosis who were admitted to the Department of Neurology at the University Clinical Center in Katowice between 2018 and 2023. We collected the data basing on patients' medical history, and the data that we collected included the form of MS, the duration of the disease, the disease-modifying treatment, as well as the coexisting autoimmune diseases. A total of 531 patients were included, comprising 383 females and 148 males. It is worth noticing that the mean age for MS patients with autoimmune disease was slightly higher, which was 45.3 years, in comparison to the mean age of MS patients without an autoimmune disease, which was 42.3%. 85.5% of our patients had relapsing remitting form of multiple sclerosis. In all, 10.8% of patients presented with autoimmune disease, while 9 of them, which was 1.1%, had more than one autoimmune disease. If we want to answer the question whether autoimmune diseases are more frequent among patients with multiple sclerosis, we need to compare them to the frequency of autoimmune diseases in general population. So 10% of general population has an autoimmune disease, in which we can distinguish autoimmune thyroid diseases. They account for 5% of all autoimmune diseases. We can split them into hypothyroidism, which makes up for 0.7%, Hashimoto's disease 2%, and hypothyroidism 0.2 to 1.3%. Diabetes mellitus type 1 is also an important autoimmune disease, and it accounts for 10% of all autoimmune diseases. Our study has shown that the most commonly reported conditions among our patients were also hypothyroidism, which was 4.2%, Hashimoto's disease, which was 2.7%, hypothyroidism, 1.2%, and diabetes mellitus type 1, 1.1%. Other reported autoimmune diseases accounted for less than 1% of our patients each. Patients with multiple sclerosis were found to have a longer duration of patients with multiple sclerosis and coexisting autoimmune disease were found to have a longer duration of MS, which was 11.2 years, in comparison to the 9.4 years in a group of patients without another autoimmune disease. The results have also shown that the expanded disability status score in patients with another autoimmune disease was slightly higher than in the group without another autoimmune disease. Among patients with multiple sclerosis and another autoimmune disease, the relapsing remitting form was significantly more frequent than in the group of patients without another autoimmune disease. As I bring my presentation to an end, I want to share the conclusions. So the patients who have both multiple sclerosis and another autoimmune disease tend to have relapsing remitting form of multiple sclerosis, have a longer disease duration and higher disability according to EDSS, sorry for spelling mistake. Among patients with comorbid autoimmune diseases and multiple sclerosis, the predominance of thyroid disorders was noticeable. The prevalence of diabetes mellitus type 1 and intestinal disease in multiple sclerosis patients was found to be increased. Thank you, and feel free to ask me questions.
Thank you for the presentation.
Thank you very much for your presentation. Very interesting. I would like to know if you perform your own separate diagnostic approach for the diagnosis of these autoimmune diseases, or your knowledge was based on the data derived from the medical history or from the medical documentation, for example?
Our data was derived from the medical history of patients that we had access to. So we know that some of this data was not complete. So we had to go through the patient's medical history and elicit the patients that had another autoimmune disease in their history. And yes, we based it on the medical history.
The same question I wanted to ask you, but related with this, I would like also know what about immunotherapy in these patients? Are these patients treated with DMTs or without? Because it's also related with some coexisting autoimmune disease.
So the patients that we include in our study are undergoing immunomodulating therapy for multiple sclerosis. But your question is about treatment for other autoimmune diseases?
No, DMTs, multiple sclerosis.
Okay. So yes, the patients are undergoing the treatment for multiple sclerosis, and we gather the data that we are gathering the data that about the treatment of our patients, and we want to use it in the further investigation and compare, for example, the period of time that the patients are undergoing the treatment for multiple sclerosis with a co-occurrence of other autoimmune disease, because we also think that this can correlate with coexistence with another.
It's a very important issue because some of DMTs, MS DMTs, would be related with inducing coexisting autoimmune disease. So from the methodology, taking into account the methodology, it is very important to evaluate this kind of treatment because it would be related with some inducing autoimmune disease. And just a comment, because this issue is also very well known in our experience. So you should, in my opinion, add to the title of the presentation add on the end one side experience only, because not coexistence of autoimmune disease in Poland, but only just in one side experience. Thank you.
Yes. And I would like to add that we also looked at the issue that you mentioned, that immunomodulating treatment can induce other autoimmune diseases, and we want to further investigate this topic as we go on with our study.
Thank you for the presentation, for the discussion.
Thank you.
And the next presentation is assessing diagnostic accuracy and safety in navigated versus frame-based stereotactic brain biopsies.
Good morning, dear jury and participants and listeners. My name is Małgorzata Gola, and today I have a pleasure to present a study comparing navigated and stereotactic brain biopsy. And there are several types of biopsies, but in this particular topic, I am focusing on the two types, the stereotactic and navigated. And the main difference between them is performance of the procedure. The stereotactic biopsy using the stereotactic frame, which is attached to the patient's head, and then imaging is performed to establish coordinates. And the in the navigated biopsy, the patient's head is immobilized in Mayfield frame, and the needle biopsy is observed in real time. And there is also endoscopic biopsy, which is using in ventricular system tumors, and open biopsy, which is very rarely used due to newer and safer techniques. And in our clinic, patients are qualified to biopsy with brain gliomatosis. When suspected low-grade glioma in eloquent areas, when the patient refuses refusion consent for resection, and some midline tumors. Like any medical procedure, biopsy also is associated with some complications, and the most common of them described in literature include abscess, hematoma, brain edema, seizure, infection, fistula, and death.
And in our study, we considered the patient's age and gender, symptoms, risk factors, type of biopsy, amount of collected samples, tumor localization, was the material obtained diagnostic, and hospitalization length and complications. And our study group consists of 112 patients, including 54 women and 58 men. And the collected data was analyzed in statistical software. And this is what we got. The most common tumor location was frontal area and deep part of hemisphere. And the most common symptoms reported by the patients was muscle weakness, cognition and memory problems, aphasia and headache. And most common comorbidity was arterial hypertension. And if it comes about hospitalization, average length of the hospitalization was 5 days, and the longest hospitalization was 25 days. And most patients didn't require rehospitalization, but if necessary, in most cases, it resulted from repeat biopsy or resection tumor. And complications after procedure occurred in fewer than 5% of procedures, consist with current literature, and 4 patients experienced bleeding, and 1 patient developed fistula. And both navigated and stereotactic biopsy showed an over 80% success rate. And to sum up, both stereotactic and navigated biopsies are procedure with low risk factor of complication, and there were no significant difference between both of the methods, and nor was there any significant impact of risk factors on complications after biopsy. So based on this analysis, we can conclude the experience and skills of the operator have decisive impact on effectiveness and safety of biopsy. And thank you for your attention, and feel free to. Okay.
Yes, it's time for the discussion.
Congratulations on your presentation. I have several questions. First, could you tell us what was the cause of the longest hospitalization? It was 25 days, if I remember correctly. And what was the complication? Okay, the fistula. And the other thing, are there any contraindication for such a procedure?
Infection of the area of the biopsy. It was low rate in Karnofsky scale, and yeah, that's all.
Okay, and my last question is, well, the idea of the biopsy doesn't matter. What was the procedure is to get the material for the histological assessment. Do you have data from those patients? Were there any false negative biopsies that evidently there was a tumor on the MRI imaging and you haven't found any pathology? Okay, thank you.
Dr. Sylvia Peretek, if you want to ask a question, you can.
Yeah, I would like to ask a question. You distinguish between aphasia and cognition. So I would like to ask about that. What is the reason for distinguishing aphasia from cognitive dysfunctions?
Because more patients, I would like to more patients have. Okay, a lot of patients have aphasia, so I would like to
I don't know how to speak it. I would like to.
You would like to underline that a lot of patients had aphasia? Because from my part, I would like to say that sometimes aphasia is not treated as a cognitive disorder, but in fact it is. It is a language disorder. So it is a cognition, you know. Yeah. Thank you very much.
Thank you for the discussion, for your presentation. The next presentation is Advancing Spinal Surgery Outcomes through MEP and D-Wave Electrophysiological Monitoring.
Welcome everyone, especially, sorry. Let's start. Welcome everyone, especially a distinguished jury and you, dear colleagues. My name is Maciej Laskowski and I'm very happy to present you our work. Let's start by outlining the basis of our work. Spinal cord tumors account for 2 to 5% of the all central nervous system tumors. They are broadly organized into 3 main groups. Depending on the spine compartment they invade. The first group, extradural tumors, account for 55% of the spinal cord tumors. The most common in this group are metastases. The second group, intradural extramedullary tumors, account for about 40% of the spinal cord tumors. The most common tumors in this group are schwannomas and meningiomas. Now let's move on to the core of our work, intramedullary tumors. They account for about 5% of the spinal cord tumors. Mostly the most common type of tumors in this group are astrocytomas and ependinomas. Astrocytomas are more common in children, where the ependinomas are more common in adults. I want to show you the general outlines of the intramedullary tumors resection. So let's begin. The surgery begins with the situating the patient in a prone position with the head fixed in the neutral position. Then the laminectomy is performed. After that, there is a dural opening section. After dural opening, the incision in the midline or paramidline dorsal avascular part of the spinal cord is made. Then the tumor is resected and then removed. Here are the same steps in the procedures. However, the pictures are from the operating room. Here you can see the myelotomy, then the tumor resection, removal, and here is the empty tumor bed. The perfect spinal cord surgery is where the tumor is completely removed. And there are no neurological deficits. So basically, to assess the neurological status of the patient, the neurophysiological monitoring is performed. Traditionally, it was the CCEP, somatosensory evoked potentials. However, they mostly show us the sensory pathways, not motor pathways. So as our understanding evolves, so our techniques, we moved towards using the motor evoked potentials, supplemented by the D-wave monitoring. Now let's move on to the basics of the motor evoked potentials. Here you can see the electrode placement during this procedure. So basically this method is based on the stimulating the motor cortex through transcranial stimulation. It generates the motor evoked potentials that are recorded from the peripheral needles, subcutaneous needles in the muscles fener, hypotenar, tibial, and sometimes triceps. Now let's move on to the second type of the neurophysiological monitoring, the direct wave. Here on the pictures A and B, you can see the on the picture A, you can see the electrode placement. So basically there are two electrodes. One is rostral, R is placed above the tumor. The second C caudal is placed under the tumor. And on the picture B, you can see the waveforms of these recordings from direct surface of the spinal cord. This is the waveforms before the surgery. And picture C illustrates the situation where there is a corticospinal tract injury during the resection of the tumor, which is showcases of the dropping the amplitude of the caudal C electrode. Now let's move to our work. Our main goal was retrospective analysis of the patients patients with intramedullary tumors operated with neurophysiological monitoring in years 2005 and 2024. In our study group, there was 40 patients. 42.5% had ependinomas, 22.5% patients were with astrocytomas, and 35% were with other rare intramedullary tumors. The average age of the study group was 38. There were 53.3% male patients and 46.7% female patients. The MAP examination underwent intraoperative MAP examination underwent 15 patients. The MAP plus D-Wave test underwent 25 patients. And it is very important to note that all the surgeries were carried out using devices from the same manufacturer, aim and the same operator, which is very important. Now let's move on to the basis of our work. So basically we divided our work into two groups. Patients with MEP monitoring and MEP plus D-Wave monitoring. We assess the neurological status and the 0th day after the procedure and at the discharge. To assess the neurological status, the tutor operator proposed the McCormick scale for grading the neurological function in spinal cord. And now moving on to the results, let's start by discussing the first group, the patients, 15 patients with MEP neuromonitoring. The mean neurological condition before the procedure in a McCormick scale was...
I'm sorry to interrupt. Please move to the conclusions.
1 minute, please.
Okay.
The mean neurological condition before the procedure was 1 point and the median was 2. In the MEP plus D-Wave, the mean neurological conditions was 2, the median was 2. And what is the most important from this slide, the surgical results in MEP status unchanged was in 71%, temporary deterioration in 21%, the permanent deterioration in 7%, and in a group with D-Wave, the status unchanged was in 62% patients, temporary deterioration in 40% patients, and permanent deterioration in 24% patients. Now, moving on to the conclusion, disappearance of the motor evoked potentials are significant prognostic values. However, as our study shows, the introduction of D-Wave monitoring did not statistically change the treatment outcomes of the patients. However, D-Wave monitoring can have a continuous insights in the functional of the spinal cord. And also the treatment outcomes depend on the type of the tumor. Here is the literature, and thank you for your time.
Thank you very much.
Because the intraoperating neuromonitoring is really important for the intramedullary tumors, but is it also important and useful in the extramedullary tumors in the spinal cord?
Thank you for your question. It's a great question. As you said, the basic we can use those neurofunctional monitoring during the intramedullary tumor resection. However, during we can also use during the extramedullary tumors resection, because those tumors could also affect the neurological functions by compressing the spinal cord or the spinal nerve. So it's better to perform the procedure with those kind of monitorings, because you can avoid the important corticospinal tracts and make the surgical outcomes better.
Okay, and is there some part of the spinal cord that requires the monitoring of the sphincters?
The sphincters, to monitor the sphincter functions, the new monitoring of the medullary cone is performed.
Can I have one more question? If I got it right, you said at the beginning that out of this huge amount of time, because it was like 19 or 20 years, you gathered the data, those patients that you chose for your study was the only one who were selected for this kind of monitoring during the study? Is it a standard procedure to monitor during this operation, or it was introduced some years ago?
Thank you for your questions. Those type of surgeries are very rare. There are not so many procedures. So the biggest limitation during this study was the study group. It was 40 patients. We cannot perform any serious statistical analysis. But going back to your question, the newest guidelines for the intramedullary tumors resections basically tell us the more neuro monitoring, the better. However, it depends on the operator preference, and also it depends on the personnel experience. However, for example, in Italy, the rules are very strict. You cannot operate without using the neurophysiological monitoring.
So your answer raises one more question. So who is performing this monitoring during the procedure?
During this procedure, the operator, so the neurosurgeon, which is resecting the tumor, is performing the neuro monitoring. So basically, if anything goes wrong, if the amplitude of those monitoring are dropping, as the operator stops surgically resecting the tumor and tries different approach to not injure the corticospinal tracts.
Thank you for taking questions, for the answers in the presentation.
Thank you so much.
The next presentation is a closure of a patent foramen ovale in the prevention of cryptogenic stroke.
Okay, can I start? Good morning, everyone, and welcome to my presentation. I'm Natalia Cardas, and I would like to present a topic about closure of patent foramen ovale in the prevention of cryptogenic stroke. Okay, thank you. My talk is particularly relevant because stroke is the second leading cause of all deaths, accounting for 19.6% of all deaths in 2019. What is more important, the number of cases and incident rate of ischemic stroke will increase across all age groups and socio-demographic index quantities between 2020 and 2030. Next, we have TROS classification, which is composed of 5 subtypes of ischemic stroke, but I would like to focus on the last type, which is a stroke of undetermined etiology, which means cryptogenic stroke. Over 1/3 of patients with stroke of undetermined etiology has association with PFO. And PFO of diverse sizes may be found in more than 1/3 of normal individuals. And the cause of effect relationship between PFO and stroke is more likely in young patients, not burdened with traditional stroke risk factors and with cortical stroke. We have to remember that it's still disputable whether morphologic features of PFO may contribute to the occurrence of stroke. And there we have some guidelines. And for example, European Cardiology Society improved that patient between 80 and 65 years of age with embolic stroke or TIA and a high probability of stroke being associated with PFO should be qualified for PFO closure procedure. But how can we, how this relationship can be established? And let me introduce the ROPE score. ROPE score has been proposed as a method to estimate the patient-specific PFO attributable fraction, which means the probability that documented PFO is causally related to the stroke. And if we have a score more than 7 points, it means that it's associated with high probability of PFO stroke cause and effect relationship. In addition, structural and morphological features of PFO are taken into account in our study. Okay, so there we have neurohydratization, and our team consulted 189 cases. Majority of our patients were women. And we had to went through various factors which could potentially influence the team's decision. Let's start with demographic factors. The mean age is the same in qualified and not qualified group, but underlying gender, female were more common in non-qualified group. And there we have neurological factors. I have to mention that all patients had to have had a previous stroke or TIA to be qualified, which is really important that number of stroke, hospitalization due to stroke or TIA and changes in the CNS without stroke or TIA were statistically significant. In, of course, non-qualified group. Neither diagnosis of coagulation disorder nor presence of coagulation disorder were found to be statistically significant. And there we have cardiac factors. None of the results were become statistically significant. Comorbidities. I have to mention that migraine, arterial hypertension, and lipid dysfunction were statistically significant, but arterial hypertension and lipid dysfunction were really common in a qualified group. Migraine was in the opposite group. And Now we have nicotinism, endocrine disorders, neoplasm, that were statistically differs in these two groups. And unirate analyze reveal the factors with this chance of positive qualification are female, imaging changes without stroke or TIA, migraine, endocrine disorder. But the strongest impact on positive qualification had hypertension, lipid dysfunction, number of stroke, and hospitalization due to stroke. But multivariate analysis showcase imaging changes without stroke or TIA as a factor reducing the chance of positive qualification. The factor that had the strongest impact on positive qualification was the number of strokes. And to conclude, factors increasing the chance of patient qualification for PFO closure are a large number of strokes, hospitalization due to stroke, arterial hypertension, lipid disorder, nicotinism, and the presence of endocrine disorders, migraine, imaging changes without stroke, and female gender reduce the chance of qualifying for PFO closure due to lack of relationship between PFO and potential acute cerebral ischemia. And this is my bibliography that cover everything what I wanted to say. And thank you very much for your attention.
Thank you very much for the presentation.
Thank you for your presentation. I have a few questions. Previously, there was a correlation between migraine and the PFO presence. Your study showed that presence of migraine was one of the factors that allows to at least take the potential of qualification for the PFO closure. Could you comment on this?
I know that many studies wanted to show the relationship between migraine and the presence of PFO, but in our study, migraine were present more in the patients without stroke or TIA in the past. So maybe that's why the correlation is not like in the another study.
And what was the main reason of disqualification for the PFO closure? This group.
Of this group with migraine.
No, in general.
In general, it was, for example, migraine without a stroke or a TIA, because the stroke or TIA was like a clue of the qualification. For example, neoplasm, because we were probably, the team was a little bit scared of the consequences of the treatment, because it's not like a really easy procedure. It's a surgical treatment, the closure of PFO. So probably that's why they didn't want to risk with the patient, for example.
And did you follow the patients after the PFO closure?
No, but it is idea for the second part of our project, and I hope that we will conduct in the figures.
Good luck. Thank you.
Thank you.
Thank you for your presentation. I'm curious, who was the person who qualified to the PFO closure? It was a neurologist?
The neurosurgery team consists of neurologists and cardiologists, but for example, if we have patient with migraine only, the neurologist transfer the patient for the classification. But sometimes we didn't have stroke, but AF in the past months, and the cardiologist transfer. It depends on the main cause associated with probability of association PFO and stroke in further months or years.
Thank you.
Thank you for the discussion. Thank you for your presentation.
Thank you very much.
And it's time for the last presentation of the session. It will be gender differences in clinical presentation and course of Parkinson's disease.
Good morning. My name is Karolina Klubikowska, and I want to show you the presentation about gender differences in clinical presentation and course of Parkinson's disease. So Parkinson's disease is a neurodegenerative disorder with unclear etiology, mainly connected with loss of dopaminergic neurons and the presence of alpha-synuclein deposits with substantia nigra in midbrain, which forms Lewy bodies. It's age-related and has progressive character. In Poland, Parkinson's disease affects 5 to 24 out of 100,000 patients per year, making it the second most common neurodegenerative disease. Parkinson's patients present both motor and non-motor symptoms. The main and usually first symptoms are bradykinesia, muscle rigidity, tremors, and gait disturbances. Non-motor symptoms may be presented as autonomic dysfunction, cognitive abnormalities, and psychiatric symptoms. Research findings show that Parkinson's disease is progressing differently in men and women. So men have a higher risk of developing the disease, and they also experience an earlier time of onset with motor symptoms. Women experience more frequent non-motor symptoms, with some exceptions, like REM sleep behavior disorder. Women show a more poor response to treatment for bradykinesia, and they also report a lower quality of life. The studies show that a mortality rate is also higher for the group for women with Parkinson's disease. So having reviewed these findings of other research, we also did our research on patients from our clinic. The goal of our study is to find the differences in the time of symptoms occurrence, the symptoms manifestation, severity, and therapy used in the Parkinson's disease according to the gender of patients. In our study, we initially analyzed 353 patients with Parkinson's syndrome who were hospitalized at the Neurology department of the Professor Kornel Gibinski University Clinical Center of the Silesia University in Katowice between 2018 and 2023. 59 of them were excluded from the study because they didn't meet criteria for idiopathic Parkinson's disease. So in the end, we analyzed 294 patients. 115 patients were women and 179 were men. The information we collected concern the age of patients when the symptoms started, the severity of Parkinson's disease based on the MDS-UPDRS Part 3 in the off state, and during the onset of the disease symptoms. The percentage of patients for whom the tremor was the first symptom, the doses of levodopa and the doses of other Parkinson's disease medications, and the other therapies like DBS therapy, apomorphine, or duodopa. So here are our results. As you can see on the presentation, only the treatment for the Parkinson's disease with the DBS-STM therapy showed a statistically significant different result between female and male. The analysis indicated that men presented symptoms earlier than women at age 55 compared to 58 for women. This difference was not significant because the p-value was higher than 0.05. In terms of initial symptoms, 63.5% of women experienced the tremor as the first symptom compared to the men, 52.5%. The p-value for this result was even higher, which is showing that is also not statistically significant. We analyzed the disease severity based on the MDS-UPDRS Part 3 scores in the off state compared to the first years when the symptoms started. The chart is showing the average MDS-UPDRS scores for both men and women. Men being the blue dots and women being the red dots. We also made a trend line to better visualize the results. The results showed a consistent progression of symptoms over time, which was similar for both genders. In addition, we analyzed gender differences in doses of levodopa and doses of other Parkinson's disease medicaments. The difference were also not statistically significant because the p-value in both cases was above 0.05 and the patients were treated with similar doses. We found significant difference between male and female in the percentage of patients treated with the DPS-STN therapy. The research showed that more men, because 10.61% chose treatment with the DPS-STN therapy compared to the women when it was only 3.48%. The p-value for this result is 0.0245. The difference between men and women in choosing the other treatments like duodopa or apomorphine were not that significant. So our findings show that Parkinson's disease is progressing only slightly different in men and women, but we noted significant difference with the DPS-STN therapy. This research suggests that gender plays a role in the selection of treatment for Parkinson's disease. Thank you for your attention.
Thank you for your presentation. It's time for our last discussion of this session.
It was a great presentation. Could you tell us what's your thoughts about why the men choose the DBS more often than the women?
Yes, we've read some other studies about this as well. And it was suggested that it was mostly based on some of the studies were done in the US where they use either private or public insurance. So it was suggested that more men have access to private insurance. So it could stem from better access to private care as well. And women also have less access to caregivers, so they are not referred for DBS as much. Also, more women decided not to take part in the surgery after being qualified, and it could stem from not wanting to shave their heads and stuff like that.
Regarding the same issue, did you mention the statistical analysis and comparison related with age? Because in my opinion, I would like to know how the differences are related with age.
Yes, to be honest, we didn't focus as much on age, but mostly on the gender of the patients. But
yes, but in my opinion, it is very important to know what was the mean age in all evaluated groups, and also to have this kind of conclusion. It was important to improve the knowledge about other factors which would be related with this result and this conclusion.
Yes, of course.
Thank you.
If there are no more questions, thank you very much. Yeah. All the submitted papers have been presented. I congratulate all of the presenting authors and the participants of the neurology and neurosurgery session. At this point, I would like to ask the president of the jury, Professor Monika Adamczyk-Sowa, for a few words to sum up the session.
Dear organizers, dear Michał, dear colleagues, it was my really great pleasure to be with you today. Thank you for the invitation. All the presentations, all the studies, topics are really very fruitful. So from this place, I would like to thank you for the participation, and I would like to encourage you to work with neurological topics because, as you know, neurology, mainly neuroimmunology, are currently very highly developed area, and I would like you to invite you to work with these topics with our tutors in our clinical sites. So thank you so much for today, and see you next year.
Thank you very much, Professor, for these words. I'd like to cordially invite you for the decoration and closing ceremony of the SIMC 2024 conference, which will be held in Theatre Rialto in Katowice on the 27th of May at 6 p.m. On the behalf of the Student Scientific Association, I would like to thank you all for participation in this session. Brawo. I jako, że oficjalną część sesji skończyliśmy, to pozwolę sobie na parę słów organizacyjnych po polsku. Od godziny 12 na głównym holu budynku kampusu Wydziału Medycznych w Katowicach będzie rejestracja.